Welcome back to the Explainer. I am so glad you're joining us today because we're tackling a topic that is highly requested, and honestly, for millions of people, it's deeply, deeply personal. Today, we're looking at post cesarean physical outcomes. Specifically, we're going to explore the anatomy, the everyday reality, and a potentially game changing 3-minute surgical solution for what is commonly referred to as the C section shelf. If you're a focused learner who loves understanding the underlying medical realities behind common physical experiences, well, you're in the exact right place. Okay, let's dive right into this.
35 months post C-section with an apron belly. This quote right here is straight from a Reddit user on a C-section support forum. And it is absolutely crucial that we start with some empathic validation today. When we analyze the sources for this explainer, we see just how frequently and urgently women are discussing this very real physical concern online. I mean, for nearly 3 years, this user has been dealing with an anatomical shift that is rarely discussed in standard pre-op consultations.
Or take this user simply asking about the post C section pooch in a fitness forum. I want to validate these colloquial terms right off the bat. Whether it's called an apron belly, a shelf, or a pooch, patients are actively searching for answers. It is a widespread shared experience. Unfortunately, a lot of patients are led to believe this is just some isolated aesthetic issue, or maybe even a failure on their part to, bounce back. But as our source material reveals, these terms actually describe very specific physical anatomical realities. And finally, consider this question from a Facebook support group. What have you done to lose the C-section pouch? This beautifully captures the sheer frustration and confusion surrounding this whole topic. Patients are out there crowdsourcing medical advice because they just feel left in the dark. And that perfectly sets up our transition today. We're going to take this exact frustration, step away from the internet forums, and look directly at the clinical reality of what is actually happening right beneath the skin. Grading post-surgical contours. Now, what's really interesting about this is that when we enter the medical realm, colloquial terms like pooch and pouch are completely replaced by objective grading. By establishing a grading system, surgeons and researchers can objectively measure, discuss, and ultimately treat the structural shifts that happen after cesarean delivery. Look at the structural overhang and the deep indentation at the scar line. Neutrally speaking, the tissue above the scar is essentially tethered down, creating that protruding effect right above it. This is the visual medical evidence of the shelf. So let's break down the exact clinical definition of what we're looking at here. This outlines what researchers call a grade 2 abdomen. It's characterized by moderate suprapubic bulging that actually covers the cesarean scar. It involves moderate subcutaneous fat and skin excess. Interestingly, it's noted that there is no abdominal wall diastasis. That means this isn't about the abdominal muscles separating. That's a completely different issue. And finally, there's a minimal to moderate scar depression. This shows us that the shelf isn't just surface level, right? It's a deep anatomical reality driven by how the tissue heals and tethers at that scar depression. But it's also really important to note that severity can increase significantly. Here we see the clinical designation for a grade 4 contour assessment. At this level, the patient experiences a very deep, indrawn caesarean scar depression. Historically, correcting a grade 4 structural shift has required extensive, major interventions, things like a full abdominoplasty, commonly known as a tummy tuck, along with scar and apron resection. Think about that for a second. It often requires a major secondary surgery just to correct the anatomical tethering caused by the initial procedure. The Scarpa fasciculation. So what if there was an anatomical revelation that could potentially change everything from the very beginning? Meet the Scarpa fascia. It's a distinct membranous layer located deep within the subcutaneous tissue of the anterior abdominal wall. Basically, it's like a natural internal support band sitting right beneath your skin but above your muscles. In our clinical solution today, this specific layer of tissue is the absolute hero. When surgeons cut through the abdomen during a C-section, they pass right through the Scarpa fascia. The million-dollar question is, what happens to it when they close the patient back up? 2 to 3. That represents a classic micro-investment for a massive macro return. According to the source text, actively closing a 15-centimeter Scarpa fascia incision with a running suture typically requires merely 2 to 3 extra minutes of surgical time. Literally. That is it. Taking just 2 to 3 extra minutes to locate this specific fascial layer and stitch it back together independently can provide the structural support needed to potentially prevent the skin from collapsing into that deep, tethered scar depression.
And there's another absolutely crucial clinical detail that makes this so revolutionary. A high body mass index has not posed a feasibility issue for this closure technique. This is massive. Unlike some literature surrounding full abdominoplasty, where a high BMI might complicate the procedure or disqualify a patient entirely, researchers specifically note that a high BMI does not prevent surgeons from successfully finding and suturing the Scarpa fascia in those quick 2 to 3 minutes. It's a highly accessible technique for a really wide range of body types.
Safety and clinical evidence. Naturally, whenever we discuss adding a step to a major surgical procedure, the immediate question is about patient safety, right? Let's move to this and see how the data builds, because as focused learners, we don't just want to know if something works in theory, we want to know what the safety data says when it's actually applied in the operating room. And the data here is incredibly reassuring. Taking those extra 2 to 3 minutes to close the Scarpa fascia results in no increased rates of infection beyond the normal baseline. There are also no increased rates of seroma, which is a buildup of fluid under the skin. The only real technical challenges surgeons face generally arise in repeat C-section cases, and that's simply because previous existing scarring can distort the anatomy and make that fascia a bit harder to find. But overall, it's a highly accessible, low-risk addition to the procedure. However, we always want to be perfectly objective about where the medical science currently stands. The current reality is that the recommendation for routine Scarpa fascia closure is largely based on extrapolated evidence and expert opinion from leading surgical centers. While it's incredibly promising and makes perfect anatomical sense, actually, the future need is very clear. Formal, randomized controlled trials and prospective cohort studies are still needed to definitively demonstrate its impact on long-term contour outcomes across massive populations. So, what does this all mean? Which brings us to our final, thought-provoking question for today's explainer. Will routine Scarpa fascia closure become the new standard of care in obstetrics? Imagine a world where a simple, low-risk, 3-minute step becomes the universal norm, potentially saving millions of patients from the physical frustration and secondary surgeries associated with the post-surgical contour changes we've explored today. It is such a fascinating intersection of anatomy, technique, and patient advocacy. Thank you so much for joining me to explore the science today. Keep questioning, keep learning, and I'll see you in the next explainer.